Good morning. I would like to do the recording for Chapter 11. Chapter 11 pretty much talks about childhood and neurodevelopmental disorders. And as we talk about, there are going to be certain areas that we're going to be focusing on really kind of heavy. But as we talk about some of the developmental or childhood developmental disorders, we have to go back and look at the risk factors. And this pretty much with all of the disorders we've talked about so far about the risk factors, some things that could predispose a client to have disorders. Um, as we look at risk factors being genetic, neurobiological, we kind of talked about that. Cognitive factors like what falls under cognitive factors would be temperament, and that refers to the overall mood, attitude, the behavior that a child habitually uses to cope with demands and also experience of the environment. So they may throw in what we call a temper tantrum, trying to adjust or cope with the environment or whatever is going on in the environment, causing them to act out. Resilience is the capacity to recover quickly from difficulties. The resilient child, they have used the following characteristic. They're able to adapt to the environment, to the changed environment. They're able to also they good usually have good problem solving skills. They also have the ability to perceive long term futures, and also they also have the ability to form relationships, long term relationships. So again, these are just some of the factors that falls under cognitive temperament and resilience. Also, some other factors could be environmental, what's going on in the child's environment. Some adverse childhood experience could be, you may see the acronym ACE, ACE, that means adverse childhood experience. It includes things like emotional, physical, sexual experiences, neglect, um, mental illness could be due to parents or substance abuse users. Also, negligence is the most prevalent form of childhood abuse in the United States. So again, these are some environmental factors. Also, when we're looking at the child, the other factors we have to look at ethnicity from a worldview, their religious, and also their socioeconomic status. These are all risk factors that could cause a uh, childhood and some neurodevelopmental issues. This is a case study. Mimi is a 13-year-old child of a single mother who suffered from PTSD from growing up in severely abused, being severely abused herself. This has also made her agoraphobic. Mimi's mother is unemployed because of her emotional instability. Mimi's mother does love her, but often keeps her out of school to take care of her. Despite all of this, Mimi, who lives with her mother, develops normally. You hear the team resilience you. So, what are some of the characteristics that you may see in this child? Like I said, resilience. They may have the ability to change the ability. I'm sorry, they adapt to the changes in the environment. Also, they could develop good problem solving skills, and then they also could have perceive or have long term positive a future. Again, it just depends on what type help that child gets, and so that's one some examples there as we talk about Mimi. So as we look at the audience question, and I kind of told you from the beginning and the answer here, but we're going to go ahead and read it. Mimi's mother is not abusive or neglected, but she does put her child at the same risk by being overly controlling, keeping her a bit too close, largely out, out of worry of fear. She worries about her child, so she keeps it kind of close to her. Which of the following is the most prevalent cause of child abuse? And I kind of told you that neglect is the most prevalent form of child abuse in the United States. This is according to the United States Department of Health and Human Services. Okay? And I told you guys that even if we suspect abuse and neglect, we have to report it among the child and the elderly population. They are vulnerable population, which we are mandatory reporters. As we assess the child with 4 developmental disorders, we have to we collect our data, and some methods that we use to collect data could be interviewing, screening, testing their neurological, their physiological, or intelligence status. Now, I mentioned too in one of our discussion in class, we have to use the appropriate tool that's age appropriate. So we wouldn't use an adult tool to assess a child. So you want to use that appropriate tool. In addition to the patient, we look at multiple sources. We interview the parent, the teachers at the school, other caregivers. Again, those we have structured questionnaires, behavior checklists that we can use as well. So again, the mental status exam, you all are familiar with that because you're going to be utilizing that in psych. So that tool is available for you in your course. Developmental assessment also looking at what the child is, what they've developed based on developmental milestone at a certain age. Where are they developmental? And then learning and adapting to the environment and bonding with others in a mutually satisfying way. So we want these children to be able to bond. They need to adapt to the environment. So we have to make the environment conducive as well. Make sure they have the resources that they need. Some general interventions for children and adolescents are basically looking at the behavior interventions. Play therapy is one. Bibliotherapy, which involves literature to help the child express feelings in a supportive environment. Again, that's basically what bibliotherapy means. Then again, we have what we call disruptive behavior management. When a child act out, there are techniques that we need to use. And those techniques could be things like putting the child in time out, quiet room. Then they may have to end up in seclusion and in restraint. So again, well, of course, we're going to use the least restrictive first. Journaling, writing down what triggers an episode. Music therapy, family intervention. Then, of course, teamwork and safety, teamwork and collaboration. Okay? So these are some general interventions for children and adolescents. Some others, like I just told you, kind of got a little bit ahead of myself. They may have to be in timeout for those disruptive behaviors or even seclusion restraints. Treatment modalities, again, we look at a multimodal approach. These children may have to have medication and combined with therapy as well. Some psychological therapies, your CBT, uh, where we try with the cognitive behavior therapy. This is where we want to replace those negative self-defeating thoughts with some more realistic and accurate appraisal to improve their function. So we're looking at things that may be defeating these children, these analysts. What can we do? How can we help this child replace them with positive coping mechanism? Okay. Group therapy also would be beneficial. They group therapy usually kids like to do, the adolescent, younger children use role play, and they kind of share ideas. Again, learning skills. Talk to the children, But now when we do group therapy, again, like I said, they need to be in a group of their peers, their age. So you wouldn't put a 10-year-old in a group with a 17-year-old. So it needs to be age appropriate. Adolescent therapy, group therapy, identifying their emotion, modifying those responses also, talking to them, focusing on their, what type peer. A lot of times with adolescents and children, it's a lot of peer pressure. So again, you want to address those specific issues among their peers. If you want to talk about things that's specific to adolescents, you want somebody in that age group to talk to that age group as well, because they can kind of connect more if they are age specific. These are some of your neurodevelopmental disorders, communication disorders. We're going to talk about those. Motor disorders, tick. I'm sure y'all have heard of tick, and specific learning disorders and intellectual disability. These are just some of your developmental disorders here. And so let's talk about this case here. Victor, which is a 5-year-old, will be soon starting kindergarten, and his dad, a single father, is very anxious. I have no idea how Victor's going to make it in school. He's completely out of control. I have trouble getting him to calm down. When he was little, I was kind of proud of how active he was, running from one thing to the next. I took it as a sign of curiosity and intelligence. But as he's gotten older, he's still like that. Only he can't calm down and sit still for anything like other kids his age. Something got to change. So let's see what's going on with Victor. However, we're going to come back to Victor, but when we talk about communication disorder, we look at language disorder, difficulty in obtaining and using the appropriate language. It could be due to deficit in production or comprehension of the language, excessive, repetitive. Also, we look at speech, sound disorder. Children have problem making sound. Prime example of that, a child that has a stuttering issue, they become what? They may become isolated, ashamed to say something because they stutter. And they feel like the kid's gonna laugh at them. But these are some speech sound disorder that we may see that falls under communication disorder. Also, childhood onset of fluency disorders. I just kind of mentioned that stuttering. Social communication, problem with using verbal or nonverbal meanings for interacting socially with others. So they can't interact verbally, so or nonverbal. So these kids have the tendency to what? Isolate themselves because they have problems communicating. Motor disorders, developmental coordination disorder. These kids have impairment in motor skills development. Coordination below the child developmental age, meaning that they should be performing at a certain age, but there's a developmental lag. Also, these problems with developmental coordination disorder could have an impact, interfere with a child's ability to perform academically, or even perform activity of daily living. Sometimes these kids, when we talk about developmental disorders, they have a problem sitting or walking, difficulty jumping or performing tasks such as tying their shoelaces. There's a lag there. There's a developmental lag there. They may have some serious impairment in skills development, coordination. Again, they may be identified as so they avoid certain tasks or certain activities. They avoid being around people because they are developmental lag. So because they are stereotyped, and so when they're stereotyped, they be ashamed. So some stereotypical or movement disorders, they be doing things repetitive, like hand waving, rocking, banging their head, nail biting, and teeth grinding. So again, this is stereotypical movement disorders. And I'm sure you've heard the term tic disorders. This is where they have sudden non-rhythmic and rapid movement or vocalization. They just kind of like jerk, and they can't control that movement. Provisional tic it's another one. This is they have a single multiple movements, vocal tic for less than a year. So this is how they are diagnosed for the most part. Then if it's persistent, they have a combination motor and vocal, and then again none more than a year. So this is just how disorders are classified. Then you have Tourette, and then this is where they have multiple motor tic and at least one vocal tic for more than a year. So you've ever seen anybody with Tourette syndrome? They kind of jerk their head and they have that awkward movement, and then it impairs their ability to speak. Again, how we treating tic disorders. Usually, we can use comprehensive behavior interventions for these clients, which is a habitual reversal of those techniques. We work with those clients to help them to be aware of building up an urge to use muscle responses in competition. And again, trying to help them control basically those movements for the most part. And also, there's another technique, deep brain stimulation is used when they've tried other conservative treatment and they don't work, and they use what we call deep brain stimulation. This is where a fine wire is threaded into the affected area of the brain, and then that wire is connected to a little small device, handheld device, that deliver electrical impulses. So again, this method can turn the device on. The client can turn that device on to control their tic and shut it off when they go to sleep. So as long as like they're walking around in the day, they can use it whenever they can turn it on. When they're going to sleep at night, they can turn it off. So a wire is, like I said, it's inserted into the brain. It's connected to a little handheld device. So that's what we call deep brain stimulation. Then, of course, your medication, antipsychotics, and your alpha-2 adrenergic agonists also could be used to help with that. So I would encourage you to look on your medication list and kind of look at some of those antipsychotic medication. Also, other treatment for TIG could be, I'm sorry, I've done that one. I apologize. Other specific learning disorders could be things like dyslexia. They have problem reading, dyscalculia, problem with math, and then this graphia is where they have problem expressing themselves, um, written expressions. Intellectual development disorders. You may see here the acronym IDD, and this is where a client have a deficit in their intellectual functioning. They have problem with reasoning, problem solving, planning. They have problem with abstract thinking, and then again, then you have social functioning. This is where they have impaired in language and communication. Um, then daily function, where they have problem with the activity of daily living, and it also can help impact their functioning at school or work and performing self-care tasks. It is thought to be the etiology of it. The cause is usually it's the problem with maybe something happened during pregnancy or prenatal development. Could be also environmental influences or could be also connected to a certain medical condition. So as far as caring for these clients, we're going to apply the nursing process. So again, we want to make sure we do our assessment, nursing diagnosis, also treatment plan. So assessment, like I said, we want to make sure we use the appropriate tool, um, that we age appropriate. We need to assess for any signs of potential neglect or abuse. And as far as our nursing diagnosis is concerned, you gather all your data, then you come up with your nursing diagnosis. Your treatment plan, of course, going to be individualized. It should be realistic. Uh, Family members should be involved. The teachers, if they are going to school. Again, everybody needs to be involved that it has an impact on this child. Or making sure that their needs are met. Okay, and then of course we go through the evaluation process. Did we meet our goals or our outcomes? Then the next disorder I want to talk about is autistic or autism. It's a persistent deficit in social communication, social interaction across the multiple contexts. These class again, they're stereotyped or they may have repetitive motor movement, such as use of objects. They may have one object, one little toy that they want to play with. They have problems speaking. Also, they kind of like line up their little toys, organize them. Again, they have probably echolalia. I have a great niece that's artistic, and she does a lot of things repetitive over and over again. She's non-talkative. She's only 3, but she's in therapy, so I can see some progression there. Again, these children they do not have eye contact, and they get extremely upset when you're trying to discipline them, like you take something away from them. They have problem with their rituals, doing things the same way. Like I said, they may line up their toys the same way. And when she walks into the house, she goes in one particular room initially. That's her first when she walks in her grandmother's house. She has a ritual going into that one room, staring at a picture. So she does that repetitively. Again, like I said, with these kids, we make sure we have to understand and maintain, develop a relationship with them. Safety is a big issue for these kids because they bang their heads. They like to stand up on things, how they like to jump. Again, as far as their nutritional, they like to walk and eat, so you have to give them finger foods, something they can walk and eat it or come back to. They can be hyperactive, very hyperactive. They also can be hyperactive, but the most of them are hyperactive. So again, we have to make sure that the environment is safe for these kids. Uh, as far as the symptoms, they must be present in early developmental period. And like I said, I noticed this with her when she was about maybe 8 months old, because of that eye contact. She never would give you that direct eye contact. Again, so they require substantial support. Uh, Again, they get them in early intervention is going to be the key for these children. As for again, we're going to do our assessment for these kids. Like I said, early intervention program is going to be the key. we try to get those, trying to change her behavior. So we use behavior management with rewards. If she does something well, we kind of try to reward her. But again, you have to also correct it. But again, like I said, I think when she was about a year old, she did like to climb up on high stuff. So you have to watch him at all times. She knocked her shoulder out of socket. So that was a biggie. So again, first thing social work's gonna look. Okay, was there good family support? Is this a form of neglect? But it was actually an accident. I'm sorry. So again, safety is a big concern for these kids. As far as treatment pharmacology, we use is used to improve their readiness, decrease their anxiety, and also help with their compulsive behaviors, and then, like I said, the agitation. And you could basically the most commonly used drug, and then again, they don't use them until they get a certain age. So um, and risperidone, which one of your second generation antipsychotic, risperidone, and a or Abilify has been approved by the FDA to treat those children with autistic. Also, some other psychological therapy, behavior therapy. Again, early intensive behavior intervention. Like I said, got to get them in to help with their language, their cognitive skills. And there is a early Denver model. It's a tool that's been out there for a long time. It's called the Denver model. So early start the Denver model, one-on-one interaction, joint play, activity routine with the adult and the child. So again, going back over with that one-on-one interaction is going to be the key, getting those kids into therapy. And then when they get into therapy, like I said, the parent or the adult needs to also, when they not in therapy, they need to keep that therapy going, joint playing with the child or whatever. And also when the child, like I said, they use those antipsychotic medicines, risperidone or propofol. However, they may also need some stimulants to treat if they become hyperactive, impulsive or inattentive. And then, so again, SSRIs also the most used again with these patients. They also the SSRI is going to help with the moods, reduce the anxiety as well. Okay, so again, just keep that in mind. Some of the treatment. A patient is scheduled for a deep brain stimulation. Which of these disorders is most likely to improve from such treatment if all else has failed? Remember, I told you with tic disorders, uh, if they used all other cognitive and medication and it didn't work, so they resort to DBS, deep brain stimulation. So again, when all other treatments, conservative treatment has failed, then the deep brain stimulation is used. Like I said, it's a wire, this fine wire is threaded into the affected area of the brain, and it's connected to a small device implanted under the skin, and then they have that little machine they can control it. Like I said, it can be turned on to control the tick, and then it can be shut off. Usually, when the clients go to sleep, they'll turn it off. Uh, Attention deficit hyperactivity disorders. This is where a client that has inappropriate degree of inattention, impulsiveness, and hyperactivity. Uh, Again, ADHD is the term. Again, what we need to do, we need to make sure certain that we do a thorough assessment on this client. We need to assess their level of physical activity, their attention span, their talkativeness, their social skills. What are there any comorbidities that this client is having in conjunction with ADHD? And then again, looking at our nursing diagnosis and our outcome. So with these kids, we want to be able to improve, increase their social relationship, and then help these kids with their self-esteem, help them with positive coping skills, and also get the family involved as well. As we look at Victor again, we're going back to this case study, has started kindergarten and skills exhibit the same problem his father expressed frustration earlier. His hyperactivity, in particular, his inability to listen when his dad tries to correct or slow him down. So Victor's assessed today for the following. We assess him for his level of physical activity. We look at his attention span, his talkativeness, his social skills, and are there any comorbidities with Victor. So then, as we look at goals, some things that we can implement, we can look at group therapy, individual therapy, family therapy, how we can manage his disruptive behavior. Again, do a behavior contract. Okay, Victor, if you do well, if you do not exhibit any negative or agitation or disruptive behavior within the next hour or 2 hours, then we may want to do a contract with him and then reward him for following that contract. Then counseling, modeling, role play, planning, ignoring. This is when behaviors are determined by the staff to be attention seeking and not dangerous. They may be ignored. So sometimes uh, the child may do things to get attention. So you can sometimes things can be ignored if they're not it's not dangerous, causing harm to the client. So, you know, and then using signals or gestures, words or gestures or eye contact to remind the child, okay, you need to get under control now. Just look at them, okay, and say, okay, time out. So again, physical distance and touch control. We don't want to touch a kid, give them their distance because touching them may aggravate them, okay? But again, we can put them in timeout. And like I said, using signals or gestures like, okay, and then things like I said, if it's not detrimental, we can ignore them. And then because they'll try to get your attention, I'm just going to do this until I get some attention. But if it's nothing, causing any harm, we can ignore them. And then implementation, intervention, psychosocial intervention, redirect. This is a technique that used after an undesired or inappropriate behavior is to engage or re-engage the child in appropriate activity. It may be setting limits, firm limits, gesture, or physical prompts, like I said. And then additional affection, they just may just need somebody to talk to show them that they care. Then use of humor is okay. Uh, Classification of intervention. This is breaking down a problem situation that a child experience can help the child understand the situation. This can be done verbally using little worksheets, and then again, it has to be age appropriate. This is where we're trying to help that child motivate themselves. Looking at intervention where they can say, okay, this works for me. So self motivation. Then restructuring is changing the activity in a way that will decrease the situational frustration. Frustration. Then, like I said, physical restraint. That's going to be our last result. Evaluation. You're going to focus on the symptoms and then the severity. So basically, they also with ADHD focus on academic performance. This is something. Did they perform better? Were they more engaged in their activity of daily living? Were they in like a social relationship? What about their personal perception? Do they have a positive self-image or self-esteem? Again, like I said, looking at those, these are some things that we can measure, or evaluate. Were there any improvement in their behavior, their academic performance, and so on? So Victor is diagnosed with ADHD after being assessed both at home and at school. To begin with, a psychiatric mental health nurse works with Victor to help him change his pattern of misconduct. Working with Victor's father as well to help him develop internal control and to help them both improve coping and support. Victor expresses delight over a few CBT games aimed at the problem solving skills and conflict resolution. Use of medication also discussed as a possibility. So we're looking at more therapy, more intervention with him. So again, based on this question, which statement demonstrates that Victor's dads understand the diagnosis of ADHD? And the answer is B. Victor performance will increase in a structured setting that provides reward for appropriate behavior. So this is where Victor's father understands that that has to be some structure, and also we will that rewards will be provided to Victor if he act appropriately. Like I said, you may write that Victor will not show any signs and symptoms of agitation within the next 8 hours. So if Victor didn't show any signs and symptoms of agitation or didn't act out, then Victor could be rewarded, for his behavior. Some treatment modalities for medication be used to increase his attention span and direct uh, behavior. Also for parenting training, behavior therapy, and then also cognitive behavior therapy. So again, which child would be most difficult to diagnose for neurodevelopmental disorder? So A, of course, the younger the child is, it's going to be more difficult to diagnose, okay, than older children because there's limited language skills and coping and emotional developmental at age 3. So the older they are, the better you're going to be able to make a diagnosis. The last question, a 4-year-old frequently lashes out in anger at adults and others. The child's style of behavior is an aspect of what? Temperament. Like I said, temperament is a style of behavior a child habitually uses to cope with the demands and expectations of the environment. So they throw a temperament based on not being able to get their way. So this ends the lecture for chapter 11. We'll do more discussion in class today. Thank you.